Hey everyone, this is your lecture for your pharmacology for Module 19 on drugs related to sexuality. We're first going to begin with different drugs used to manage the symptoms, problems related to menopause on females. Okay, so the purpose of them is to alleviate the manifestations of menopause, which you should have covered or will cover all of this in MedSurge 2. The symptoms that the female will go through. Options are hormone replacement therapy, which you will often see just written as HRT or spoken of as HRT. Selective estrogen receptor modulators, or SERMs is what they're referred to, which is also a hormone replacement with lower doses, lower levels of hormones of estrogen to decrease some of the adverse effects that go with it. SSRIs, or selective serotonin reuptake inhibitors, and SNRIs, serotonin norepinephrine reuptake inhibitors, which we covered in mental health, but we will touch on those again to keep your knowledge base. Okay, so on your hormone replacement, the one I want you to focus on is your conjugated estrogens. The most common one is your Premarin, used to treat the moderate to severe hot flashes, changes in and around the vagina because they get vaginal wall thinning and atrophy, and any other symptoms they may get due to this lower dose, the lower production of estrogen or loss of estrogen production in their body. Most healthy, recently menopausal women between the ages up to age 59 or within 10 years of menopause can use this hormone replacement therapy for relief of hot flashes and vaginal dryness. This is the most effective treatment for the symptoms. Sometimes, if it's just specifically for vaginal dryness or painful intercourse called dyspareunia, that's their only symptoms or the major symptoms, they may just use a low-dose vaginal estrogen, like a Premarin cream, instead of taking systemic. Any systemic use of estrogen has an increased risk of blood clots in the legs or going to the lungs. The older the female, or if they smoke, the risk is much higher. So the risk at 49 to early 60s is lower. As the age goes up, it gets more so. There are risks of congestive heart failure, breast cancer, pulmonary embolism, and stroke. The lower dose estrogen progesterone combination, starting right as they enter menopause or early after menopause, is the safest time to use them. And when a female loses the production of estrogen, their cardiovascular risk goes up, so replacing low-dose estrogen progesterone will decrease their cardiovascular risks. For a long time, the hormone replacement therapy was what they did for all women, and up until 2002. Then there was an initiative that found that it was too dangerous, and there was a whole thing of not using it. That's when a lot of these bioidentical hormone replacement has come into play. It's been around for a while, but the newer studies are showing that they're not really effective. Some women may think it helps some of their symptoms, but it doesn't decrease some of the other risks, and it doesn't help with the decreasing the cardiovascular risk. So the one I mentioned, the conjugated estrogen or Premarin, is used to help with those vasomotor symptoms, decrease osteoporosis risk for postmenopausal, because that is one of the postmenopausal problems, is loss of the bone density, or worsening bone density, I should say, and vulvar and vaginal atrophy. Does come in a tablet. It can come in the vaginal cream or even suppository form, or the tablets if they need systemic for the vasomotor symptoms. The vaginal cream is not going to impact anything other than vulvar and vaginal atrophy symptoms, so they may take it by mouth. And again, the older they are, the worse the risks are for complications such as the heart failure. Go to the next slide. So contraindications: if they have a history of breast cancer, thrombophlebitis, if they've ever had a DVT, deep vein thrombosis, a pulmonary embolus, if they have hepatic disease. Caution if they have asthma, and I'm not sure why, but the epilepsy, migraines, especially if they're hormone-induced migraines, cardiac dysfunction. The side effect is the weight gain, water retention, and depression. So sometimes they're used in combination with an SSRI, SNRI, or sometimes just the SSRI or SNRI is effective to control the symptoms, and they may just use the Premarin cream for the vaginal symptoms. Teaching: avoid smoking, or report if they have any history of clots, they develop a clot, and they have normal bleeding. Prolonged use may increase risk of cancer. Okay, so adding to these, a lot of the same precautions you take with the birth control pills or oral contraceptives. Teaching them signs and symptoms of a clot, signs and symptoms of pulmonary embolus, abnormal bleeding. So if they are postmenopausal and then all of a sudden they start having vaginal bleeding again, which they should not, unless they're just having the spotting as they're going into menopause. Prolonged use, the longer period of use, the higher the risk of developing a cancer. Also, some interactions that are listed in your Pharm book. I was interested here because it talks about black cohosh. Black cohosh, it says it may and donkey may increase estrogen activity. Black cohosh actually works in some people for postmenopausal symptoms. There were studies that were inconclusive, and finally they found it had to do with the woman's chemistry, that some people it was extremely effective. That's because it will increase that estrogen. So if somebody's taking the oral estrogen, you want to tell them not to take the black cohosh. They should not do both because it might increase the estrogen in the body and cause complications. But again, they can do the vaginal because of not having a systemic absorption. Ginseng and saw palmetto may also increase the effects. St. John's wort, that some people take this herb for depression symptoms. It can decrease the concentration of their estrogen from their Premarin. And then avoid grapefruit juice. Like I said, I often just say avoid grape juice and everything, but if somebody is on Premarin, taking it orally tablets, you want to tell them to avoid grapefruit juice. Also, on hormone replacement, this goes for males and females, whether it's testosterone or estrogen, watching their cholesterol levels because it can increase their triglycerides and their LDL or their bad cholesterol, low density, and their total serum cholesterol. May impact their thyroid function tests. Teach them to watch for cardiovascular change, like an increase in their blood pressure, fluid retention, chest pain, shortness of breath, numbness, tingling in their extremities. Teach all those things and be aware of those. We are covering the Premarin specifically for menopause, so we're not going to go into other reasons why you might have a hormone replacement and watching things like pregnancy, because we're talking postmenopausal for this, so we're only talking about the oral route and the vaginal route. Okay, so the selective estrogen receptor modifiers, or SERMs, they can be used for postmenopausal symptoms. A lot of what I found is that they are used for osteoporosis. Some examples: raloxifene, asfenia, and Duvet. Duvet is a combination of SERM, or this selective estrogen receptor modifier, and the conjugated estrogens such as you find in Premarin. This may be prescribed for younger women that have osteoporosis or the postmenopausal. The raloxifene, asfenia, these SERMs are actually used in breast cancer treatment, so these may be used if a woman has a history of breast cancer, needs this for the postmenopausal osteoporosis. This is an effective, safe treatment for them. Oh, hang on. I did want to add that raloxifene is in your Pharm textbook or Pharm book on page 987. I was reading up on the different ones, and I put the raloxifene because I spelt it wrong on the slide. I'm sorry. RALOXIFENE. Sorry about that. And then oxyphenia, I saw your text misspelled it. It is an N, and the text had an M. So between the text and I, we both have messed up. So OSPHENA, and the raloxifene should be RALOXIFENE. There is a black box warning on the SERMs for increased risk of deep vein thrombosis, pulmonary embolus, women with congestive heart failure, or at risk for coronary events, or increased risk for death due to stroke. This is major assessment and teaching that has to be done, teaching the symptoms of a pulmonary embolus and heart problems. Caution if they have any cardiovascular disease, obviously, and if they have increased risk for thromboembolism, if they have abnormal bleeding. The major reason for using SERMs, again, is to reduce the bone resorption. These, like the other estrogens, monitoring their total cholesterol, their calcium levels, bone density. For this should have an improvement in their bone density, but monitoring and assessing for pulmonary embolus, DVT, teaching them to immediately report chest pain, shortness of breath, dyspnea, tachycardia. Any postmenopausal women should always be counseled to take calcium and vitamin D supplements. And briefly, I want to touch on mentioned previously, but I didn't put a slide in here on your SSRIs. Sertraline or Zoloft is a common one that is used for postmenopausal. Also, we'll talk on this again with the sexual dysfunction. An example of your SNRI that may be used will be your venlafaxine or Effexor for postmenopausal. Bupropion or Wellbutrin can be used. It's more used for the sexual dysfunction, but sometimes it is used for these symptoms. Okay, so menstrual dysfunction. There's not much for us to cover on here. The goal for dysmenorrhea, painful or abnormal bleeding, dysfunctional uterine bleeding, or DUB, would be to stop or suppress or slow down or lessen the menstruation, the blood flow, the cramping. Most commonly, if there's no contraindications, is doing combination oral contraceptives, the low-dose estrogen, progesterone. They may put in an intrauterine device, or they may give progesterone, Depo-Provera shots. Additional management, NSAIDs. We've covered NSAIDs before, your ibuprofens, not aspirin because of the bleeding. SSRIs again, maybe your fluoxetine or Prozac, paroxetine or Paxil, citalopram, which is your Celexa, again your sertraline, which is your Zoloft. Those are SSRIs. They will be monitoring the iron, possibly doing an iron replacement because of the blood loss, if they have an iron loss due to this. Remember, you can be iron toxic, so they may just need a replacement with their vitamins if they are low taking iron. Just remember, complications only of constipation. They may have tarry looking stools that are not actually blood, but it's due to the iron. And that iron is difficult for us to absorb in our gut for it to supplement, so they should not take it with milk products. Usually take it on an empty stomach with like orange juice or some vitamin C source to help with absorption. It can cause nausea and may be difficult to tolerate. Okay, so sexual dysfunction pharmacology. Start with the male sexual dysfunction. Most commonly is erectile dysfunction, sildenafil, which is your Viagra, tadalafil, which is your Cialis, which is the most common one, so just focus on both of those. They work by being a vasodilator, so the caution is priapism, which is a prolonged erection of 4 hours or longer. There's also that risk of optic neuropathy, so they need to report if they have changes in their vision or loss of vision, spots or anything like that. Vasodilator, because it's a vasodilator, you're going to need to watch for hypotension. Just think of those things if you dilate the vessels, so they may have some peripheral edema. Mostly it's changing in position if the blood pressure drops. If they are on an antihypertensive, they need to take caution with their Viagra. They need to make sure that they are cleared from the cardiovascular state if they have cardiovascular disease to be sexually active. The text mentioned hormone replacement with testosterone. Testosterone is not to be used for sexual dysfunction unless they truly have a hormone deficiency. Most common testosterone, some people get injections. The topical will be androgel. Lots of precautions with testosterone replacement. They have to watch their liver enzymes and their hematocrit, because their hematocrit can get too high and they have to get off of it. If they're using the topical, they cannot have that gel, that cream is very dangerous to children or pregnant women. It can cause defects in the fetus. There is a risk of breast cancer. You do need to teach men to watch their breasts for this. I only saw that actually once. It turned out to be a growth in the breast, but it wasn't cancer on a male. So we forget to teach males about checking for breast cancer. So if a male is taking a testosterone replacement, it does they do have an increased risk for breast cancer and need to know that. Another that I did not list on here, or maybe I listed it on the females, again, is your bupropion or Wellbutrin. It's an antidepressant that's not in any particular class. It is the one antidepressant that does not cause sexual dysfunction, so it can actually be used to enhance people that are having problems with a sexual dysfunction. It can have an effect of decreasing appetite, so you need to watch for any development of anorexia or problems with weight loss or loss of appetite when they're on this. What else do I need to tell you on this? With any antidepressant, especially elderly, watching for risk of suicide. Not to take this with excessive alcohol. And in the elderly, which may be taking this for the sexual dysfunction if they're older, more sensitive to being more sedating. I think that's about all you need on this one. Let's go to your females. Oh, sorry, forgot something. On testosterone, the side effects of testosterone can be acne, weight gain, hyperglycemia, the priapism, which I told you is a prolonged erection. They could have kidney stones, jaundice. I said you need to watch their liver enzymes. And I told you about watching their hematocrit. Okay. So let's go to the female. Usually it's estrogen replacement, increased genital sensitivity and lubrication. So sometimes it's a vaginal estrogen. They may take it, or they may take it orally. If they, if the woman has had a hysterectomy, they can take estrogen alone. If a woman has an intact uterus, even though they're postmenopausal, they have to take estrogen and progesterone combination, or there's an increased risk for uterine cancer, even postmenopausal. It's called, I think it's non-opposed estrogen. Anyway, can't think of it right now. SERMs, the selective estrogen receptor modulators, could not get that, modifiers can also be used, again keeping in mind whether or not they have a uterus. Bupropion, which I thought I had on this slide, which I mentioned for the males, that can be used for the sexual dysfunction, often if it's also related to their postmenopausal. And that is the last of the slides for sexual dysfunction.